Exam Mastery Live class. So they are going to be a rapid revision of important topics, and they're going to be quick revision of high topics. Most expected topics will be covered, and this is going to be beneficial for university exams and all. Now, looking at the core features, we are having the live classes. You can see the recorded notes and MCQs are also over there. Okay. Subscription plans for this Oracle classes are starting from basic plans, which are for a period of 3 months. Starts from 15K to then go up to the mentorship program, which are for up to an year, and price bracket is around 50K. In between these two plans of 3 months and 12 months, we have a study plan of 6 months as well, which is going up to a price range of 30K, 30,000, right? So you can see all the benefits with the all these three plans. Remember, it's only the mentorship program where you also get notes and one-to-one personalized guidance. While pre-recorded classes, live classes, and examination module, you will get in even the basic module. Okay. And book also a slot for personalized counseling session. So most welcome for any of the personalized counseling session if required. And finally, you can also use this code. Code over here is written down. That is Ankit 2020 for a few of the live classes, free live classes, as well as some discounts in the subscription as well. Right. Okay, so let's start the session over here. So yesterday we finished off with a topic. Well, we were discussing, I guess, this cubital fossa, right? Yesterday, if you have not yet seen, then go to the session that we did on last night, right? So we'll continuing from there, and next topic of the for this will be radial nerve. Okay, so let's start from this topic. So before initiating the radial nerve, few things we should be knowing that this radial nerve is actually the largest branch of brachial plexus. So first of all, first one should be clear. That's the largest branch of brachial plexus. Okay. Second thing is that this nerve basically supplies, you can say, half of the upper limb because it mainly supplies the posterior aspect of the upper limb, which includes both arm and forearm. Okay. So that therefore it's quite a big branch. And coming from which cord? It's coming from the posterior cord of brachial plexus. Posterior cord of brachial plexus, with having a root value of all this C5 to T1. Now let's see over here. So also you can see in the notes also they started with being the largest branch of the posterior cord. Not just the posterior cord, but it's the largest branch of the all the combined cords. Root value is C5 to T1 and begins where? Begins obviously from the posterior cord. Then as it is from the posterior cord, so it runs behind the axillary. Why? Because it is from posterior cord, so it runs behind the axillary artery. Okay. Then as it reaches the arm, it will reach it going behind the brachial artery as well. Okay. Then it leaves the brachial artery, and you should know it passes through which of the three spaces. The spaces that we did yesterday about the quadrangular, the upper and the lower triangular. So remember, it passes through the lower triangular intermuscular space around the scapula or the shoulder region. Then as the nerve is going into the arm posteriorly, it passes through the radial groove. The groove name is basically based on this content of radial nerve. The radial groove is also known as the spiral groove. It's also known as the spiral groove, right? Then it enters the re-enters the anterior aspect of arm. You should know where it is lying. It is lying in the lateral aspect of the cubital fossa. So first it is behind, right, the arm. Then as it reaches the elbow or the lateral aspect, it is then in front of the lateral aspect of the elbow region or lateral aspect of the cubital fossa. Okay, then it divides into superficial branch, which is mainly sensory, and deep branch, which is also known as posterior interosseous nerve, also known as posterior. Let me write its complete name: posterior interosseous nerve, which is basically motor. Okay, so it is basically supplying the muscles, and a superficial nerve, which is basically sensory. So it divides into these two branches, and then it ends over there, dividing into these two branches. Now here you can see in this image what are the different muscles that it's going to supply. Okay, there also we should know what are the different muscles that it's going to supply. So right from the arm region, it is obviously going to supply all the heads of triceps. Okay. Then it also supplies brachioradialis and extensor carpi radialis longus. You'll see a mnemonic. Mnemonic goes with the name of BEST, BEST, for the muscle supplied by the main trunk of radial nerve. So radial nerve supplies few of the main muscles. The B over here you can see it's what? It's brachioradialis. Okay. Also, B could be the lateral aspect of brachialis as well. Yes, you heard it right. Brachialis, where have you heard this name? In the anterior part of the arm. But it's a lateral half is also supplied by the radial. E refers to the extensor carpi radialis longus. S is a spinator muscle, a small muscle which spinates, known as supinator muscle. And T you can see is the triceps. So these are the muscles supplied to the main trunk of brachial plexus. And then as you can see all these muscles over there, they are supplied by the posterior interosseous nerve. This is the deep branch. This is the deep branch of radial nerve. Deep branch of radial nerve over here. Okay, and this is superficial branch that was mainly sensitive. This basic idea. Now, why is this so important, guys? Because when you talk about the applied anatomy, the radial nerve can be damaged at the region of axilla. Over here, it can be damaged at the region of the spinal groove. Can be damaged at the region of the elbow, that is around the lateral aspect of cubital fossa as well. So different of the different findings we can see. So that is why we are looking at a different muscles being supplied by it. Reviewing back just a second, we can see that it is mainly supplying the triceps in the arm region, right? And as it goes down in the lower part of arm, it supplies brachioradialis and extensor carpi radialis longus. Okay, here you can see the nerve is coming anteriorly, so it supplies over here the lateral aspect of brachialis as well. Then as it goes down, all these muscles you can see mainly the names are extensors or abductors. Where are they present? They are present where? In the posterior forearm, or you can say posterior or extensor aspect of, that is the back of the forearm over it. Extensor forearm. This is the basic idea that you need to know. Fair enough. So relations, it has the following relations. So anterior mainly it will have axillary artery, and posterior it will have the posterior wall of the axilla. That is basically the subscapulus and all. Medially, as we know that medial to the axillary artery is axillary vein, so medial to the radial nerve also will be the axillary vein, and lateral will be the axillary nerve and coracobrachialis. Okay, axillary nerve why laterally? Because it will go and supply the deltoid muscle, so it has to go laterally. In the arm, it continues behind the brachial artery. Okay, we know through this radial groove, and it pierces the fascia about 2 centimeters above elbow joint. Why? So it has to come at the lateral aspect of cubital fossa. Okay, just keep in mind, I see all of these relations and course, if you just keep on cramming it, suddenly it becomes very difficult. So just imagine, look at the diagram, see where the nerve is going. Then look at each point about the course. Think, okay, it is going from here. Just look it for 2, 3 times. Suddenly, and imagine this nerve running in your arm and forearm. Slowly, you'll adjust with the course and relations. That is how we can actually go through the anatomy part by imagining it. Okay, so looking at the diagrams, reading it 2, 3 times obviously is needed, and then imagining it. Okay, so it's really things get into your brain, into your memory. That is how things are learned. Relations, you can see, we have seen the branches, as we already know that branches wise, we can go with the muscular branches. Okay, and then also we got the terminal branch. Terminal branch are two, mainly superficial and the deep branch. It is not superior, it is superficial. Okay, so this is superficial. There's some errors in writing, which I'll correct in meeting, right? Superficial, it is sensory for the dorsum of the hand, and deep branch is basically supplying all the muscles in the posterior compartment of forearm as written over here. So here's the best, as I told you, BEST, best brachialis over here. It's a lateral half only, not the entire brachialis. And if they ask about the medial half of brachialis, who is supplying the medial aspect of brachialis, then as you know, it is the muscle of the anterior part of arm. So medial half is basically by the musculocutaneous nerve. By the musculocutaneous. That's the whole point, right? Okay, articular. So my branches are the muscular, terminal, also some sensory branches also can write, and then articular through the elbow joint. Clinical anatomy is what I told in the beginning, that why are we going through this, all these branches? See, there could be Saturday night palsy. These are very, very important points. Saturday night palsy, you have to write in the theory exam. This is palsy, PALSY, right? Palsy over here. Saturday night palsy is suppose sleeping in an armchair with the limb hanging by the side. So this chair and the limb is by the side like this, right? It's hanging down. So below you have this resistance by the edge of the chair that will compress the radial. Okay. Crutch palsy now uses of crutches, and the crutches are very, this are very tight in the axilla. Okay, or they are long crutches which are pushing more into the axilla. They can damage the radial in the axilla. Then what actually happens is, as it is supplying all the posterior muscle of the extensors of forearm, so they can be wrist drop, right? So wrist drop will be there, and wrist drop over here is very problematic for the patient. But this wrist drop is quite problematic for the patient because patient is not able to do anything. Suppose the wrist is dropped, he's not even able to hold the pen like this. Suppose holding a pen, even you need to slightly extend the wrist. So in wrist drop, there is loss of extension of the wrist. It is hanging down like this. So it is quite problematic for the patient, and it is a huge problem for the patient. Just imagine this on yourself for a second to understand the gravity of the situation. Okay, so you can see over here the child night palsy can lead to the wrist drop. One thing over here, and right. So these are the important points of radial nerve. Let it come back. If the question comes to you like radial nerve, you start with some introduction, root value, and then try to add some as much force as possible. For course, see, you can even draw the muscle, draw the nerve, and then think, okay, in the arm it is going like this, in the axilla it is like this, in the arm it is like this. Which is muscles or which spaces can it pass? Then how where it is in the forearm, what are the different branches, and try to expand it during the course. Okay, and relations is not that difficult. Remember, as it is coming from the posterior cord, so in front will be the axillary artery, middle will be the axillary vein. Okay, posterior will be the posterior wall of axilla, and laterally will be the branch of the posterior cord only that is going to the deltoid muscle. That is mainly the axillary nerve. This is how you can even write about the relations. Then relations done, then a diagram, then some branches, muscular branches, sensory branches, and then your terminal branches and all that you can explain a bit. Clinical anatomy is very important, right? And few things over here like where will be the sensory loss, where will be the wrist drop, and all these things, and a couple of images, and that's sufficient to end with the clinical anatomy. Next topic over here is the profunda brachii artery. Now remember, this is the main branch of which artery is the main branch of brachial artery. So wherever the word profunda is there, remember the main meaning it is known as the deep. Okay, remember the muscles in the front of forearm. When we learn the muscles in front of forearm, we say flexor digitorum profundus. So profunda means deep. So this profunda brachial artery is also known as the deep brachial artery. Therefore, in brachial artery, you can actually feel the pulsation of the brachial artery. We did the brachial artery last night. And we saw over there that, okay, brachial artery, you can have the pulsation in the medial aspect of the arm. Profunda is a deep brachial artery, so you won't be feeling its pulsation very easily. Those are deep. So profunda brachial artery is the main artery of the posterior compartment of the arm. It is running with the radial nerve in the radial groove. So this artery is basically running in the groove along with the radial nerve, which we just saw. Okay, so if we can't palpate it easily. Of course, you can see it just becomes just below TS major where the brachial artery starts. It passes through the lower intermuscular septum. Okay, passes from posterior middle aspect into the lower intermuscular space, that is the lower triangular space, in the spiral groove, and terminates by dividing into anterior posterior descending branches. So remember, if you know a bit of course of radial nerve, you can use that course in case of profunda brachii artery as well. Okay, so this artery are different branches you can write. So as you can see around surrounding areas, so you can start with the deltoid branch. Okay. Then these two are collateral arteries. Wherever the collateral arteries are written, it is middle, not middle, it is middle collateral artery. Okay, MIDDLE. These collateral arteries are actually going down into the region of elbow, and they'll anastomose the vessels around the elbow. So these vessels over here, they are forming what? They are forming the vessels, forming the anastomosis around the elbow. You see over here that they accompany the radial anastomosis, the radial recurrent artery, radial collateral. The middle collateral artery will anastomose with the interosseous recurrent artery. Then for the artery, we see muscular branches and also nutrient artery to humerus. Why? Because this artery is close to the bone. Okay, this artery is close to the bone, and therefore it gives nutrient artery to the humerus. Fundamental artery branches. Don't forget to draw a diagram in any question which is around 2-3 marks or more than that. Try to draw at least one diagram. Even if you are poor in drawing, try to draw a diagram showing whatever you have written. That is also only what you have to show. Okay. Okay, next we come to the topic of forearm and hand. We have seen some nerves and vessels. Let's come to forearm and hand. Forearm, we should know that lies between the elbow and the wrist. So it's very basic. Arm is from shoulder to elbow, and from elbow to the wrist, we have the forearm. This region is the hand region. Okay, then muscles of again forearm is actually divided into two compartments like the arm. We have an anterior compartment, we have a posterior compartment. The anterior compartment is also known as the flexor compartment. The posterior compartment is also known as the extensor compartment. Simple as that. Muscles in front of forearm, now they are divided into a superficial and deep group. So if you look at the front of forearm, here a lot of muscles are there. Some muscles, if you just cut the skin and fascia, you will see the muscles over here. They are the superficial group, which includes around 4 to 5 muscles. Then in the forearm you have two bones. So lateral is radius, medial is ulna. Some muscles are very deep in the front of forearm, which are attached directly to these bones, all around the surface of these bones. Those will be known as the deep muscles. Okay, like you see in the profunda word is for a deep. So flexor digitorum profundus will be a deep muscle. So superficial, there are around 5 muscles to be more precise, and deep, there are around 3 muscles. So total around 8 muscles are there in the front of forearm. And most of these muscles you will see are supplied by which nerve? They are supplied by the median nerve, barring a few muscles like the flexor carpi ulnaris and the medial half of FDB, which are supplied by ulnar. So mainly, and median is mainly over here, while few muscles like 1 or 1.5 muscles are supplied by the ulnar. Ulnar few muscles. You'll see down. So these front of forearm muscles, they are coming from the common flexor region. And don't forget that this common flexor region is located where at the medial epicondyle of the humerus, also known as the common flexor region. Now, a short note if can come of the superficial muscles of forearm. You'll see an image. But remember, as we discussed earlier on in different topics also, that if you name any muscle over here, 2, 3 things that you should be answering for the muscle is where the muscle is originating, where it is inserting, or you can say different attachments. And nerve supply in action. Nerve supply in action is very important. Blood supply, see whichever blood vessel is over there. So brachial artery divides at the level of cubital fossa into radial and ulnar arteries. So obviously those arteries supplied. That also you can write. Mainly these 4 points: origin, insertion, nerve supply, and function. So nerve supply again, see over median nerve. Now here, sometimes students feel a bit worried about, so not able to remember the names. Okay, so in the case of muscles, mostly the name of the muscles, they themselves explain the action of the muscle. Okay, or the extent of the muscle from where to where it is going, or the action of the muscle. For example, here pronator teres. So this muscle will be doing what? This muscle will be pronating. The main action will be pronation. Now, pronation, supination. This is supination. This is pronation. Pronation, supination is basically between radius and ulna. So this pronation movement is, or supination movement will be basically between radius and ulna, and it's a radius bone that is basically moving in it. So remember, these pronation muscles or this supination muscles will be attached mainly between radius and ulna only. So you have pronator teres. Teres means a straight muscle. That's the shape of a muscle. Pronation means pronation. So you can see that for pronation, we don't need other bones. We need mainly radius and ulna. So this muscle arises from, you can say, the ulna and goes and inserts into the radius, moving the radius. So be it pronator teres or pronator quadratus, there's another pronation. They will be attached between radius and ulna. So pronator teres over here, coming to the second one over here, that is the flexor carpi radialis. Now look at the name. Flexor carpi radialis over here. Okay. So I am flexing the carpals on the lateral side. That's the name. I will be in the flexor compartment going to the carpals on the lateral. Why lateral? Because it is radialis. Simple as that. So you can see it is coming from the common flexor origin going to the second and third. Now numbering all this from the thumb side. So these are second and third, and these will be second and third metacarpals over here. This flexor carpi radialis is going from common flexor origin to the second third metacarpals. Again, nerve supply is median nerve. And what will it do? The name of the muscle, that is what it will do. Then the third muscle over here is a palmaris longus. So it is a long muscle, it's going to the palm. And basically, it continues as palmar aponeurosis. Once you do a dissection in this area, cut the skin and just some fat, then you see a tough fascia over here known as palmar aponeurosis. Similarly, you'll see in the foot as a plantar aponeurosis. Okay, so this palmaris longus continues as palmar aponeurosis. And again, supplying by which nerve? The medial nerve, and it will tense the palmar fascia. Fourth muscle in the superficial part. Superficial, we said five muscles are there. Fourth muscle is flexor carpi ulnaris. So again, it is a flexor muscle going to the medial aspect. Why? Because ulna is a more on the medial side of forearm. And therefore, you'll see over here that this flexor carpi ulnaris, it goes into the medial aspect, so that is fine. But its nerve supply over here is actually not the medial nerve, but basically it is the ulnar. So that is a small correction over here. Don't worry. So it is the ulnar nerve that is supplying the flexor carpi ulnaris. Okay, and it goes into the medial carpals and medial metacarpals. So these carpals, metacarpals over there, mainly the pisiform bone they are seeing, and the fifth metacarpal. So this finger, fifth finger is the fifth, right? Fifth finger, so fifth metacarpal, and these are the pisiform and the hamate bones over here. So there the flexor carpi ulnaris will go. The fifth superficial muscle is a flexor digitorum superficialis. Okay. So again, look at the name. It is going to the digits, not to the carpal or metacarpal. It is going to digits. But to be more precise, this one in the digit we have how many phalanx? Three phalanx are there. You can see a proximal phalanx, a middle, and a distal phalanx. This MTS, it reaches where? It reaches up till the middle phalanx. You should know this clearly. It reaches till middle phalanx. So you have three bones in your fingers except the thumb. Thumb only has two bones, proximal and distal phalanx. Thumb has only two phalanx, but these four fingers, they're having three bones. So between the three bones, they have two joints. You see, if I flex my finger over, I have two joints. There's a proximal interphalangeal, that is a distal interphalangeal one. Okay. Now, if the FDS is only reaching up till the middle phalanx, it will only flex the PIP joint, that is proximal interphalangeal. Okay. So, in read over here that it four tendons through carpal tunnel into the base of middle phalanx. Okay, that is what you need to know. So if you understood this, then it is going to flex, not the DIP already written over here. Again, FDS nerve supply is median nerve and a strong flexor of wrist and fingers, not DIP, and weak flexor of elbow also. So you should know all these muscles we have seen, their nerve supply is mainly median nerve, except this FCU over here. Okay, and this FCU, its nerve supply is ulnar nerve, not median. So now let's come to the deep muscles. Okay, so deep muscles of forearm. As we said, there are basically three muscles in the deep. So which muscles you have? You have flexor digitorum profundus. Now profundus means deep. Two, three things you need to know that this is a hybrid muscle. Okay, so its nerve supply is from your median nerve as well as the ulnar nerve. You can see over here. This is hybrid muscle. And second thing, it goes into the distal phalanx, D phalanx over here. These things you should know that it is going to the terminal phalanx, that is distal phalanx, and it is a hybrid muscle supplied by these two nerves over here. Function, you can see it flexes the DIP over here, right? Now, second, the deep muscle is flexor pollicis longus. Now, the word pollex over here, it means what? The pollex means the thumb. So, you have a long muscle going to the thumb, which is on the flexor aspect, simple as that. As I said, the name of the muscle itself is a big knowledge. So you can see it is going where to the base of the distal phalanx of thumb. Okay, so going to the distal phalanx of thumb. So this will flex which joint? It will flex the interphalangeal joint. So while doing this movement, okay, suppose you have to tighten anything like this, while doing this movement, you have to flex the interphalangeal joint of thumb. That is done by FPL. Flexor pollicis longus. It is again supplied by a branch of median nerve, right? Function is flexor of thumb, or to be more precise, you can say it is flexor of inter-IP joint of thumb. IP joint of thumb. So flexor of thumb would be a different thing. Flexor of thumb will simply this is also flexion of thumb. So to be more precise, it is flexor of the IP joint of thumb. That was the second deep muscle. So we had FDP first, FPL second, and third is pronator quadratus. Third muscle over here is pronator quadratus. Again, pronator. Why quadratus? Because it is quadrilateral in shape. The one pronator we said was pronator teres, it is quadratus. So it is again between radius and ulna, supplied by again the branch of median nerve only, and it pronates the forearm. So you can see even in the deep muscles, pronator quadratus or FDP or FPL, they're all supplied by median nerve. Only FDP you have this ulnar nerve. So ulnar nerve is supplying, to be more precise, 1.5 muscles. P is right over here. At ulnar nerve is supplying how many muscles in the front of forearm? It is 1.5. 1.5, when we say by one, we mean it is the FCU, full FCU, and half means the median half of FDP. It is supplying 1.5 muscles out of 8 muscles. Therefore, we know that main contributor for the front of forearm nerve supply is median. Okay, so this is how you can answer. And diagrams you can make all of these muscles, different color coding. You can see this yellow color is your pronator teres over here. Okay. And this green one is a flexor carpi radialis. This is palmaris longus. This is FCU. Now, deep to it, let me highlight here only this one over here will be your FDS, flexor digitorum superficialis. You might be wondering, sir, which nerve is this? This is also looking like front of forearm. But you'll see it is on the back of forearm. It is known as brachioradialis. You remember, supplied by the radial. It looks like it is in the front of forearm, but basically it is on the back. Or to be more precise, it is on the lateral aspect. So it is a flexor of the mid-pronated forearm. This is supination, this is pronation. This is mid-pronated. So while flexing the mid-pronated, you need a muscle on the lateral aspect of forearm, this brachioradialis. FDS will be over here, and you can see it's still deeper muscle. These will be over here, the FPL or the FDPs will be over here. So they are deep, right? You see these three deep muscles. Lateral aspect, you have FPL, lateral side. Medial aspect is huge FDP. And the small over here will be the pronator quadratus. Okay. Pronator quadratus. Okay, now superficial muscles of the forearm. Again, diagrams are there. You can just go through it. And next we come to the radial artery. So we have dealt with the brachial artery. The brachial artery, we all know it divides at the level or around the cubital fossa. You can say at the level of neck of radius. Right. So at the neck of radius, the brachial artery divides into radial and ulnar artery. So radial artery will be on the lateral aspect and ulnar artery will be on the medial aspect. Just to begin with, we should know that ulnar artery size-wise is bigger than radial artery. Remember this point by going to the topic, before going to the topic. So radial artery is a branch of brachial artery in the cubital fossa. Course tells a lot about the whole vessel. So what are these arteries? Are simply, remember, these are vessels. These are vessels running from one point A to point B, supplying areas which are coming between point A and point B. They are just like the rivers which are running between two cities or two regions. Suppose the river is going from state, say Andhra to Karnataka, or and so suppose two states. So whatever the area will be in the vicinity of the river, those cities, those areas will be supplied by those rivers. Simple as that. So the course is important. Now, radial artery, it is a branch of brachial artery at the level of neck of radius in the cubital fossa. So course starts from cubital fossa. It passes towards the wrist with a slight lateral convexity. Okay. Do remember, it will then pass through the anatomical snuff box to reach the first interosseous space. Anatomical snuff box is this concavity found in when you extend the thumb, you see concavity of the tendons over here. So this radial artery, though you palpate it over here, then it goes posteriorly into the dorsum of the hand. Okay, so it passes between the dorsal interosseous muscle and it enters into the palm, forming the deep palmar arch. So these are few things that you should know. In the forearm, you should know that a few relations for the artery. Remember. So do remember that this artery, front of the artery, you have the brachioradialis. So once you are looking at a brachioradialis muscle, you just lift the brachioradialis, mainly the upper part. Deep to the brachioradialis, you have the radial artery. That's important. And behind this, you have a lot of muscles, posterior aspect. But do remember, this is important. That brachioradialis upper part basically is in the front of the radial artery, where you can reach. Medial, lateral, other tendons are there. The artery is accompanied by vena comitantis. We have seen that in the veins also yesterday. This you can see the course of the artery over here. Okay, if you look at the course of artery, this is the brachial artery. Put a highlighter over here. This is the brachial artery. Try to see over here. This is the brachial artery in the cubital fossa. Then the neck of radius divides into radial artery and ulnar artery. Focus on the radial artery. Here it is going radial artery, and this artery over here is going like this under cover of brachioradialis. So brachioradialis has been cut over here. Okay, just to show you the radial artery. And radial artery, you can see it is palpated in this region. In this region, you palpate this artery while calculating the pulsations. Okay, then over here you can see that at this region over here, let me encircle the black color. This artery went posteriorly, where in the anatomical isthmus box. So now this artery is not passing like this over here. This artery from here, then it went behind. Okay, running in the anatomical isthmus box and piercing the first dorsal interosseous, and then this artery will form this deep palmar arch. This deep palmar arch mainly is formed by this radial artery. While looking at the ulnar artery, you can see that too ulnar artery is running on the medial aspect, and you can see it is running in front of the flexor retinaculum. And this ulnar artery over here, ulnar artery over here, is going to form the superficial palmar arch. You'll see that. So while discussing the artery, let's understand from where does it start. What's the main course? That is very important. Few relations, whatever you can remember while looking at a diagram, write about them. I am not saying write all the relations. That if you want, if you can remember all of that, nothing like that. But at least few relations you should write, because relations come from the course. And finally, in an artery over here, we come down, we now look at the branches. Okay. So what will be the branches of this particular radial artery? So this artery will give off the radial recurrent artery. Recurrent means what? Recurrent means this branch over here will recur, it will go back. So imagine there's a brachial artery, these are the radial and the ulnar artery. So this radial recurrent artery will go back. If you remember then, we discussed while discussing the profunda brachii artery, that this brachial artery at the top gave the profunda brachii artery. Let me write over here, PROF, profunda brachii. And this profunda brachii artery gave up what? A radial collateral artery, if you remember. It gave radial collateral artery. This radial collateral artery is going to anastomose with this radial recurrent artery, which is going to go above. That's the whole point. Okay, it is written also. So if you know the C, whatever knowledge you have to write down on paper in your theory exam as the question will come, or at least answer in the Viva. Or if you're giving the NEET, PG or any PG exams, then also it's going to help you. So radial recurrent artery ends by anastomosing with the radial collateral artery over here. Okay, ends by anastomosing with the radial collateral artery. Okay, as written over here. Now, palmar other branches of the radial artery are the palmar carpal branch over here. As it is going down, give the palmar carpal branch, the dorsal carpal branch, superficial palmar branch. All of these, just remember their names and try to expand them in the written format. Fair enough. Now, branches of radial artery again. Can remember this by using this mnemonic over here that you can remember. Okay. Now, exercise discuss the course and branches of radial artery in dorsum of the hand. So in dorsum of the hand over here, they can ask about the radial artery course and all. So not very important. So we are just passing through it for theory exams, obviously. But yeah, this diagram is important over here. So remember, the radial artery is going to form which arch? The radial artery is going to form the deep palmar arch. So remember, the mnemonic will be DR for doctor. So D is for the deep palmar arch and R is for the radial artery. Then you can make the diagram over here. Clinical anatomy is obviously important. Anyway, you can apply it. Radial artery is commonly palpated to measure the pulse rate. Palpated in the lower pad of forearm against the anterior aspect of the lower end of radius. More important over here is this tendon. When you are palpating the radial artery, this tendon lies, the radial artery lies lateral to the tendon of FCR. This, please remember this point. This is a question which is upcoming quite frequently nowadays. That radial artery is lateral to FCR. It is lateral to FCR, that is flexor carpi radialis. Okay, do remember this point. Okay. Okay. Fair enough. Now, as we go down over here, the palpation of radial artery, that also you can draw. This is also you can draw over here. Ulnar artery, on the other hand, we have seen a bit of ulnar artery. That the origin will be the same at the neck of radius, but then it will go medially and deep to the pronator teres muscle. The pronator teres muscle was actually the superficial muscle. So this artery will go deep to the pronator teres muscle, that you should remember. And it runs vertically downward and passes in front of the flexor retinaculum. Here you can palpate in front of the flexor retinaculum. This artery can be palpated in this area. This is the ulnar artery area, palpation area. Radial artery is actually easily palpated because you are palpating it directly against the bone, the lower end of radius. Ulnar artery can also be palpated, but not that easily. Terminates by dividing into superficial deep branches that we will see further on. So again, the course over here, you can see make both the courses. It's very simple. This diagram basically is quite simple over here. And look at how the brachial artery is dividing into these two branches, radial and ulnar artery. And as you go down, you try to form the two palmar arches over here, and some branches you can give to the digits as well. The relations anteriorly, you have this covered by the conflexor muscles. Behind you have the brachialis and these deep muscles over here. Okay, this is the flexor retinaculum. This is F flexor retinaculum. Medial, you have these structures. Lateral, you have FDS over here. Here also remember medial. This is quite important over here. In case of radial artery, we saw that medial to the artery, we had the FCR tendon. Similarly, in case of ulnar artery, medial to the ulnar artery, we have the FCU tendon. So remember these 2 points over here. And again, looking at this ulnar artery, radial artery. So here, I would like to highlight, you see this area. This area, the radial artery is not seen. Why? Because it went posteriorly. While you are seeing the ulnar artery over here, it is passing superficial to the flexor retinaculum over here. Okay, this you should know. And some muscles which have been cut over here and arteries been shown over here. Relations also there. Branches again. Just go through these branches. They are important. Main branches I am highlighting over here are the anterior and the posterior ulnar recurrent artery. Ulnar recurrent artery again. They are recurring back, so they will anastomose with ulnar collateral artery coming down from the brachial artery. If you are wondering what I am saying, see, this was the brachial, gave off radial and ulnar. From brachial, you have the ulnar collateral, if you remember, ulnar collateral artery. From ulnar, you will have the ulnar recurrent. These will be the recurrent and the anastomose of the ulnar collateral artery. Then the beginning of the radial artery, I told that ulnar artery is bigger than radial artery. Why? Because we are looking only in the front of forearm. But what about the back of forearm? For the back of forearm, you have different vessels, which from where will it come? Come from ulnar artery. So this ulnar artery is going to give rise to a common introitious artery, which is going to go back. It is going to have anterior and posterior introitious artery. So these anterior and posterior introitious artery, anterior will remain anterior and supply the anterior compartment. But this posterior introitious artery, see, it is going to go in the posterior compartment. You can see over here by passing through a gap above the introitious membrane. So this posterior introitious artery is coming from the common introitious, which is coming from the ulnar artery. So basically, the ulnar artery is also going to supply the posterior aspect of the forearm. Okay, and it is going to give muscular branches, nutrient branches, all of that by this posterior introitious artery. So remember the branches, at least their names. And if you write down in theory exam anything, then you can explain in 1 or 2 lines at least for those. And if possible, try to draw a diagram. Okay, if possible, try to draw a diagram. That's very much needed. Next, we come to the another nerve, mainly radial nerve. We did a musculocutaneous, we did axillary, we did now coming down to the median nerve. By now, we know quite a things on the median nerve. If we start from here before writing anything, what should come to your mind all of a sudden when the question comes of median nerve? Suppose there can be a short and long question of the median nerve. So median nerve, we should know from the beginning that okay, it is coming from the cords of brachial plexus. So you have, if we take this space over here, for median nerve, what points should come to our mind is it is coming from the medial root of median and lateral root of median nerve. So both medial and lateral cord, they contribute to the formation of median nerve. Next, you have seen that in the region of arm, this nerve was actually crossing. I'm just doing a rough work over here. The brachial artery. Is it supplying anything in the arm? No, it is not supplying anything in the arm. Then you know that okay, it is lying in the medial aspect of cubital fossa. These are the things which should run to your mind. And then it comes where it supplies the anterior aspect of flexor of the forearm. It supplies a lot of muscles over there. Out of 8 muscles, apart from 1.5, so it comes from 6.5 muscles are supplied by the median nerve or its branch. It also gives off a branch which is known as anterior interosseous nerve, AI. Then it will reach the hand and will supply few muscles in the hand. Okay, so in the hand, basically we have median and ulnar nerve. Ulnar nerve, I'm just doing a sort of rough work for here, is the main nerve in the hand. So median only supplies some of the collax muscles. That's a good point. These are the how it passes supplies to muscles. Then we'll come to the nerves or sensory supply of it. Sensory supply, remember, median in the hand supplies the lateral two-third of the palm and lateral two-third of the even the digits as well. You'll see sensory supply. So this is we should know that from where median nerve is coming from two cords crossing the brachial artery, medial part of cubital fossa going down, anterior part of forearm supplying. Then when it is going from forearm to hand, understand when it's going from forearm to hand, in between you have flexor retinaculum. Here comes a very important applied aspect. As this nerve is passing from at the region of wrist, it passes deep to the flexor retinaculum. Why this is important? I'm sure you guys must be knowing. Why this is important? Because here this nerve can be compressed because it is deep, and that gives rise to carpal tunnel syndrome. So whenever there's a term known as median nerve, this carpal tunnel syndrome should ring in your mind. Now, let's come to whatever discussion we can see in this notes over here. So it supplies most of the muscle of the front of the forearm, formed by medial lateral roots of the median nerve in lower part of exercise. I told you, medial lateral roots. These two roots, they come from the medial lateral cords of brachial plexus. This is how the median nerve actually starts. In the axilla, it crosses the brachial artery from lateral to medial. Okay, we have discussed this. In cubital fossa, it lies medial to the brachial artery. In forearm, it passes between the two heads of pointer teres. Now, pointer teres, if you remember, was supplied a median nerve. And this nerve passes between the two heads of pointer teres. Therefore, sometimes there can be hypertrophy of the pointer teres, compressing this nerve. So it is known as pointer teres entrapment syndrome. There can be an entrapment syndrome right over here. Okay, it can be there. I'm not saying it's impossible. It can be there. Known as pointer teres entrapment syndrome. So it has now passed through the two heads of pointer teres. It passed obviously between the forearm. In the wrist, remember, it lies deep and lateral to the palmaris longus. Why deep? Because it has to pass deep to the flexor retinaculum through the carpal tunnel. Okay, and then it will give branches to what become some thenar muscles and first and second lumbricals. Lumbricals are muscles which cause this action, pen holding position. These are the action of lumbricals. Median will supply only first and second lumbricals over here. The rest all the lumbricals, third, fourth, is supplied by the ulnar. This basic idea course we should know. Okay. Then diagram, the flow chart over here is very important. These flow charts of the nerves are very important over here. They are basically given in your Snell's textbook as well. So this median nerve over here, you can see it is the root value is given over here. Then why is this so good? Because it gives off an area, axilla, arm, forearm, and hand. So as I said previously, that if you look at the median nerve, it is not supplying any muscles in the axilla or the arm. But yes, in the forearm, it supplies a lot of muscles. So median nerve actually is a main nerve in the front of forearm. Therefore, this nerve is also known as laborer's nerve. Why? Because in laborers who are doing a lot of physical work from their upper limb, from their hand, their forearm muscles obviously get hypertrophied. Therefore, median nerve is also known as the laborer's nerve. Do remember this. Then as it reaches the hand region, it supplies some 3-4 muscles over here. 2-3 thenar muscles, that is through the thumb, and a couple of lumbricals, that's it. So in the hand, it is not supplying major muscles or not supplying the majority of muscles, but in the front of forearm, it is supplying the majority of muscles. Okay, so ulnar nerve is the main nerve over here, as I just said previously. Also, therefore, ulnar nerve is also known as musicians. The other name of ulnar nerve will be musicians. Why? Because musicians, they don't do heavy work, like they are not there to lift all those musical instruments, but they are there to make sound of or make music out of the instruments, right? So there, for the musicians, the intricate is the soft and the efficient movements of the fingers is needed. That is done by the intrinsic muscles of the hand. Therefore, ulnar nerve is known as musician's nerve, because ulnar nerve is the nerve which is mainly supplying the hand muscles of hand. Okay, so median relations, you can see the scores over here, as I told previously also, and again I'm stressing, this area is important. It's crossing the brachial artery from later to medial. Now, why is this important clinically also? Understand. Suppose a patient comes to you who has to do a amputation of the upper limb at the region of arm. So when you're cutting the arm over here, okay, you have to obviously ligate the vessels. So this brachial artery you have to ligate. Now, if you're not aware that very close to the brachial artery, you might have fibers of nerve, and those nerve fibers can come in that ligate, and that can lead to a lifelong pain around the stump of the amputated limb. Okay. So this thing, as a doctor, you should know that while ligating the brachial artery at the region of arm, or while doing any procedure even on the brachial artery in the arm, we should be clear that there's a nerve which is passing very close to it, so we have to keep it away. That's the point over here, right? Okay, now I'm going down. This is how we can show the whole course and the branches of the median nerve. This is how it is going, supplying all the muscle. There are a few diagrams. And coming to the branches, here you can see from the branches are given the muscular branches to these muscles. This anterior interosseous. Now, why is this important? See, it is a branch of median nerve. It is a branch of median nerve. So median nerve gives off a branch known as anterior interosseous. This anterior interosseous, guys, it is actually lying quite deep in the front of forearm. So it is supplying deep muscles in the front of forearm. Understand this? It is supplying deep muscles in the front of forearm. Okay, anterior interosseous nerve over here. Then it gives up palmar cutaneous branches, articular, vascular. These are all the headings, and you can fill them up. Clinic cannot be when median nerve is injured above the level of elbow features. So median nerve or nerve injury features are very important over here. Okay, these nerve injury features are very important over here. Just can go through them. So when it is injured at the level of elbow, these features are seen, and subsequently carpal tunnel will be at the level of wrist. See what's going to happen. There are deformities which are known as pointing index finger, right? Ape thumb deformity, okay? Ape thumb deformity, pointing index, and your hand of benediction. All these things will happen. We just go through one by one and try to understand what happens actually. So when this nerve is damaged at the region of elbow, the FPL and the lateral half of FDP is gone. So we are unable to bend the terminal phalanx of thumb and index finger. These will not be able to bend. Okay, they will be remain restricted like this, known as pointing index. So suppose you ask a person to make a fist, he's not able to make it completely. He's pointing index over here. Okay. Then pointer teres also gone. So what will happen? If the pointer teres is gone, there is going to be a supine position. So hand will be kept in the supine position only. Okay. Why? Because pronator teres is paralyzed. So pronation will be weakened. Okay. So hand will be in the supine position like this. Flexor carpi radialis is gone. So obviously you can't flex on the lateral aspect. So hand is adducted. Long flexors of digit are gone, as you can see, pointing index, thenar muscle. So ape thumb deformity. Ape thumb because thumb comes parallel to the other digits. That is known as ape thumb deformity. Okay. Carpal tunnel syndrome, a must know topic, guys. This comes as a short question, and it's quite common also in the society. Therefore, it's important. It's basically due to compression of median nerve in the carpal tunnel at rest. So basically, problems are in the hand. Now, understand that, as I said, that lateral two-thirds of the palm region and these 3.5 fingers, sensory supplies coming from the median nerve over here. There's a median nerve. Okay. These sensory changes will be there. Then thumb muscles are supplied. These are thenar muscles. They are supplied by median, except the adductor pollicis. So what happens actually if this nerve is compressed over here? If this nerve is compressed over here, then there are going to be sensory changes in mainly your fingers, not in palm because palmar branch is mostly superficial, coming superficial to the retinaculum. Therefore, sensory changes are mainly to the fingers, first of all. Then there's going to be immense pain, particularly in the night time. Patients may, I'm telling you the clinical uh, scenario. Patients will normally complain that when I'm sleeping in the middle of the night, there's sharp pain in my region of thumb and fingers. I have to wake up. The spine pain is so high in intensity. It's around 8 by 10. So we grade the pain upon 10. So patients may say complain about 7 to 9 or 6 to 9 in that range. So the pain actually disturbs their sleep. And slowly they will see the muscles over here are not working that fine. Slowly, the thumb goes into this adducted position also. Okay. So let's see over here what actually this what I'm telling the clinical scenario because for patients, what we see. So motor changes, you have the ape or monkey-like thumb deformity, loss of position. So the loss of movements of the thumb, and thumb slowly comes into opposition or at the adapted position. Why? Because see, adductor pollicis is the only thumb muscle that is not supplied by median nerve. So adductor pollicis will be working efficiently because it is supplied by the ulnar nerve. Then you have sensory changes. I said that okay, 3.5 digits. This means the fingers, including nail beds, will be affected. Vasomotor changes will be there, fine, because nerves, as we discussed initially while brachial plexus topic, that these nerves have sympathetic component as well. Okay, so all these features will be there. Occur in both males and females. Complain of intermittent attacks of pain. Attacks frequently occur in the night. That's quite important. Pain we referred to the area. Okay. Clinical test: paralysis of thinner muscles, unable to hold the book with thumb and other fingers. Paper holding test, all these tests, just go through it, read a couple of times, and you will understand it beautifully, right? This is the carpal tunnel. And basically, what is actually happening is anatomically, let us see over here. Let's see. You will take a, what I can say, like a TS over here, right? Like a TS over here, transverse section. Below, what you see, these are the carpal's bone over here, right? Above, what happens is this is the flexor retinaculum. It's the tough flexor retinaculum. Fair enough. Now, see what actually happens is here you have tendons, four tendons of FDP, four tendons of FDS, then you have flexor pollicis longus tendon as well. So all these tendons actually try to understand that they are covered by the tendinous sheath. In the middle of all of this, what we have over here, we have this nerve which is running. I'm not sure whether we are able to see it clearly, but try to see. Suppose this is the median nerve over here. These are tendons of FDP, and above four tendons are of FDS. Four, why? Because these four fingers. This is the tendon of FPL. Okay, so already the space is very less. Now, suppose there is any arthritis to this in this area, or there's tendinosynovitis in this area, or there is some bony abnormality, then obviously this nerve is being compressed. And the changes, the symptom signs will be shown by the patient. That's the whole point, right? Okay, so carpal tunnel syndrome, and now come to the another nerve, that is ulnar. Okay, ulnar nerve, as we discussed earlier, also known as a musician's nerve. Ulnar nerve, remember, coming from the medial cord, we did a mnemonic, that is M4U, and this U was ulnar nerve. This M4U mnemonic was for the branches of the medial cord of brachial plexus. Okay, root value of this will be your C8T1, and some fibers are coming from the C7. Now, ulnar nerve, remember, uh, what is ulnar nerve mainly supplying? It is known as musician nerve. So its main motor supply comes in the region of hand, the intrinsic muscles of hand. 1 point. In the forearm, it is mainly supplying the 1.5 muscles. In the arm, like the median nerve, it is not supplying anything. But in the first session, when we did the osteology aspect, we said there are three nerves related to the humerus bone. Axillary nerve was related to the surgical neck. Radial nerve was related to the radial groove, and this ulnar nerve was just behind this medial epicondyle. This is the important point. Why? Because in fracture of the medial epicondyle, this nerve can be damaged. So let's see. So in axilla, it lies the lower part of axilla, runs between arterial and fine. It is running medially. So in the arm, it is on the medial side, pierces the septum, because it has to go from in the arm from where to where. See, in the arm, this nerve has to go from anterior to posterior. While in case of radial nerve, what happens? The radial nerve comes from posterior to anterior. Therefore, in the contents of cubital fossa, the mnemonic is MBBR. There is no U. Why you might be thinking that, sir, where is ulnar nerve passing? Ulnar nerve in the elbow is passing behind the medial epicondyle. Okay. So understand this, that it descends over here, okay, on the posterior surface of the medial epicondyle of the humerus in the arm. And then in the forearm, it passes between the two heads of flexor carpal tunnel. And remember, it is supplying the FCU. When you said 1.5 muscle, one muscle was this. Okay, and this is known as cubital tunnel. So ulnar nerve can be compressed at that point, also known as cubital tunnel syndrome, and runs vertically downward, where it passes superficially fine in the palm and divides into different branches. And this again is a flow chart over there showing the ulnar nerve. Let me just correct a bit on this flow chart. I know, because this we have seen for many years, that there's C7 they have missed in this flow chart, right? So see what happens is Ulnar nerve is coming from the medial cord. Now, medial cord, if you remember, or let me remember it for you, is from the ventral division of the lower trunk. Okay, lower trunk, if you remember, was formed from CAT1 only. So root value CAT1 is fine. But this nerve is an exception where C7 fibers spatially come from C7 and go with this nerve. That's our point. So in ulnar nerve, remember the root value is C7 CAT1. While in all the other branches of medial cord, it is only C8 and T1. Okay, that you should know. Okay, now in the axillary arm, it is not supplying any muscle. Here, if you see in the forearm, you can see FCU and the middle half of FDP. Okay, rest are the cutaneous branches and a lot of branches in the hand region. Here I am highlighting the adductor pollicis just to let you remember about the ape thumb deformity. Ape thumb deformity seen in median of LC. Okay, course relations. So this is what you can easily write through it if you know the basic course. Sites of ulnar injury, as we discussed, it can be injured behind the medial epicondyle. Okay, in the cubital tunnel. So remember the median nerve was passing between the two heads of pronator teres. Ulnar nerve is passing between the two heads of flexor carpi ulnaris. Okay, so there the muscle, the nerve can be entered. And at rest in front of flexor retinaculum, there can be external injury over here. So median nerve over here is passing deep to the retinaculum. Ulnar nerve passing superficial to the retinaculum. Okay, so these are the sites of entrapment which are shown. This you can take a screenshot of this and there are 3-4 areas where this nerve can be injured and it can show its different parts. So do remember, ulnar injury, basically we are going to have the claw hand. We look at a patient with the fingers like this, and there will be this loss of muscles on the both the palmar and the dorsal aspect. This dorsal interosseous also muscle will be wasted, and the fingers are like this clawing overhead. It's typical of ulnar injury patient. Okay, clawing off inside because ulnar is a musician nerve, so it mainly supplies the intensive muscles of the hand, all the interossei, two lumbricals, and other hypothenar muscles. If they are paralyzed, the hand becomes like this. Why? Because extensor digitorum muscle is fine because the posterior interosseous nerve is fine over here. Okay, so that is doing its role. And your long flexor tendons coming from the front of the forearm, they're also fine. So image becomes like this, that is clawing off hand. Next, you can tell that in detail about what happens, what doesn't happen over here. And here you can see the ulnar claw hand. Now, this is a typical, they are showing the ulnar claw hand, but in reality, what actually happens is, it's this diagram, these other fingers are also bit clawed. Okay, it's not just the middle two fingers, but they are going to be, yes, sort of this picture will be seen. And the whole area over here, there will be muscle wasting. Muscle waste. Muscle wasting means it looks like muscle has disappeared. It looks like muscle has disappeared, right? So these are the important topics, guys. Then other topics also let me enlarge over here only. See in the upper limb, in the upper limb, if we just summarize, because this has been the last session. In the upper limb, see guys, go with brachial plexus being the most high topic in upper limb. And with the brachial plexus, go with its applied aspect as well. That is all the nerve injuries. So nerve injuries in upper limb is very important. Okay. Then other question that might come from the upper limb are major muscles. Look at the big muscles like deltoid, pectoralis major, even trapezius, the major muscles like this. Then question might come asking you to describe a particular compartment. Okay. Then muscles over here. Then small question like cubital fossa can easily come. Okay. Retinaculum, basically the flexor retinaculum. That these are the very high topics. Likewise, there are a few topics and a few topics that we already have done. Arteries, brachial artery, anastomosis around the scapula can be asked. In Viva, see, Viva, you don't know about the mode of the examiner, they can ask you anything. Whatever bone you pick, whatever soft tissue you have, that can be asked. In Viva, the equation is a bit different. But in theory, obviously, go through your last 5 to 10 year papers, look at the topics, go through it, right? There we have an attempt just to make a quick revision of the high topics over here. So that's all from my side, guys. If you have any doubts, anything, you can ask in the comment box as well. And don't forget about the various plans of Auricle over here. Just going through it again. These are the various plans of Auricle. and go through right from basic plan to standard to mentorship over here. You can use the code also given below, Ankit 20, and book a slot for personalized. And that's thank you for watching. You can use this social media handles right from the YouTube to Insta, Facebook, Telegram, and all these channels. And let us all make a common effort for your better uh, preparation, right? That's all. Thank you from my side, and bye bye. Thank you for listening. Thank you for watching. Thank you. Bye bye.